Welcome to week 7. This week in Pharmacology for Vocational Nursing 1, we're going to talk about vitamins and minerals. So let's talk about fat-soluble vitamins, water-soluble vitamins, and minerals. They'll be in 3 different sections. Let's get started. What are the vitamins? Well, they're organic molecules that are needed in small quantities for normal metabolism and other biochemical functions like growth or tissue repair. They attach to the enzymes or coenzymes and help them activate anabolic processes. Now, we see these in natural sources from both plants and animals, and when we have insufficient amounts, we get various types of deficiencies and effects. Ideally, we get these from the natural sources. When we don't, we have to take supplements. Supplementation has its own issues, such as megadosing or toxic hypervitaminosis. We used recommended daily allowances for years and years. Now we're moving to the daily recommended intake. Regardless, what we want to be careful with is that we're paying attention to the upper limits of the vitamins. Now let's talk about the fat-soluble vitamins. A, D, E, and K are these vitamins. They're stored in the liver and the fatty tissues. Deficiencies of these occur only after prolonged deprivation from an adequate supply or when we have a disorder that prevents their absorption. Daily intake of the fat-soluble vitamins is not required unless the patient is deficient. Vitamin A is our retinol. Food sources of this include liver, fish, dairy products, egg yolks, dark leafy green vegetables, and the yellow-orange vegetables and fruits. That yellow-orange is the carotenes, which are found in plants. It's a precursor. Regardless of whether it's retinol, retinol palmitate, or retinol acetate, we know that vitamin A functions to help with growth and development of bones and teeth. It's also essential for our normal vision and the development of rhodopsin, which is the rods and cones work in our body, in our eyes particularly. It's necessary for other processes like reproduction, integrity of the mucosal and epithelial surfaces, and cholesterol and steroid synthesis. We take vitamin A as a dietary supplement for infants, pregnant women, and nursing women. When we have a deficiency state like hyperkeratosis of the skin, night blindness, which is xerophthalmia, this is a progressive hardening of the cornea, and so vitamin A deficiency can lead to this sort of blindness. There are other conditions that result, and often we'll see skin conditions like acne, psoriasis, keratosis follicularis that are treated with vitamin A. Isotretinoin is one of the common ones that we will see. When we have this sort of treatment, we run the risk of toxicity. So what are the signs of toxicity? Well, irritability, drowsiness, vertigo, delirium, vomiting. Increased intracranial pressure in infants, so we have to be very careful with infants. The vitamin A toxicity will cause a generalized peeling of the skin and erythema over several weeks. And you'll probably recognize that this is a desired effect that occurs with a topical application in many instances. Vitamin D is our sunshine vitamin. It's responsible for the proper utilization of calcium and phosphorus. There are 2 types, our vitamin D2, our ergocalciferol. This is the one that we get from plants or obtain it through our dietary sources. And then vitamin D3, or cholecalciferol, which is produced in the skin by ultraviolet irradiation. Our vitamin D2 containing foods are cod liver oil or fish oils. That's our highest level. Our saltwater fish. Fortified foods include milk, orange juice, cereals. Animal livers, eggs, butter, dairy products are also good sources. When we have sunshine developing this vitamin D3, that's the endogenous synthesis within the skin. We have to balance that, of course, with the risk of sunburn, the risk of cancer as a result of sun exposure. What does vitamin D do? Well, it works with the parathyroid hormone to regulate the absorption of and the use of calcium and phosphorus. So it's necessary for normal calcification of the bones and the teeth. When we need to give it, or our patient needs to take it, it's because of a dietary deficiency. This may or may not be in deficiency with the endogenous synthesis of it as well. So we also use this in the treatment or correction of conditions related to long-term deficiency. You might recognize those as rickets. That's what happens when we have it in children and their bones are soft. Osteomalacia is when we have the development or the development of deficiency in adults. Osteomalacias can lead to osteopenia, osteoporosis. And then we also use vitamin D in the treatment of tetany. Tetany is an imbalance of the calcium, and remember, vitamin D is responsible for managing the calcium. Other uses of the vitamin D are the treatment of osteodystrophy, hypocalcemia, hypoparathyroidism, pseudohypoparathyroidism, and hypophosphatemia. Again, because it manages that phosphate or phosphorus, excuse me. Vitamin D toxicity can occur when we have large amounts or long-term ingestion of amounts. This can be symptoms of hypertension, weakness, fatigue, headache, anorexia, dry mouth. They may have a metallic taste in their mouth, nausea and vomiting, abdominal cramps. They may develop ataxia and bone pain. And it can progress to impairment of renal function as well as osteoporosis. You're probably saying, wait a minute, how can toxicity lead to osteoporosis if that's what we're using it to prevent? Um, well, because when we have too much of it, remember, it's controlling the calcium. So then the high calcium levels in the blood will cause the bone to start breaking down. So it's really, we have to be careful with vitamin D. Our forms of vitamin D include our calcifidiol, calcitriol, our dihydrotestosterol, and our ergocalciferol. The ergocalciferol is the one that you will see the most frequently ordered. I will say, remember that vitamin D can be ordered in micrograms. It can also be ordered in international units. There is a conversion for that. 1 microgram in vitamin D is 40 international units. So something to be aware of. Another thing to be aware of is that vitamin D is ordered frequently as a daily supplement for prevention or treatment in 2,000 unit doses or 5,000 unit doses. There is, however, a 50,000 unit dose tablet capsule available that is sometimes provided or ordered for patients. That 50,000 unit dose is taken once a week. So patient education is imperative that they know that they take that medication only once a week, not every day, because 50,000 units is a big stomping dose. Let's move on to vitamin E. It comes in 4 forms: our alpha, beta, gamma, and delta tocopherol. Dietary sources include our fruits, grains, fortified cereals, vegetable oils, wheat germ, remember that needs to be refrigerated, nuts, eggs, chicken, fish, and meat. It functions to, we're not really sure. Well, but we believe it to be an antioxidant. An unproven theory is that vitamin E has some beneficial effects in cancer, heart disease, premenstrual syndrome, and sexual dysfunction. But because the research has not proven that, the American Heart Association no longer recommends the use of high-dose vitamin E to prevent heart disease. We have to be careful with vitamin E. Dietary supplement is an indication for it. It is an antioxidant, and the highest risk of deficiency is in our premature infants. We'll go into more detail of that when we get to the pediatric course. Very few adverse effects. When we do have problems, it's usually GI tract and central nervous system. However, I will caution you, vitamin E does act as a natural anticoagulant, and therefore when you have patients that are on Coumadin, warfarin, other anticoagulants, they can have a problem with prolonged bleeding times if they take excessive doses of vitamin E. Vitamin K is our other fat-soluble vitamin. 3 types of vitamin K are phytonadione, are menaquinone, are menadione. Our body doesn't store large amounts of vitamin K. Vitamin K2, or the menaquinone, is our type that is synthesized by the intestinal flora. This is why we give it to our newborn infants, right? Because their intestinal flora is not developed yet. Dietary sources of vitamin K1 include our green leafy vegetables, broccoli, cabbage, spinach, kale, our cheeses, some of them, and soybean oils. How does it function? Well, it is essential for our synthesis of blood coagulation factors, including factor 2, factor 7, factor 9, and factor 10. We'll talk more about those when we talk about the coagulation and the anticoagulants. Our indications for it are in deficiency stage, which are actually pretty rare, but can occur with certain antibiotic therapies, as well as when we have malabsorption syndromes. Like I said earlier, we give it prophylactically to newborn infants. This is to help them to not have the risk of hemorrhage. It does reverse the effect of certain anticoagulants, warfarin to be exact, and so Coumadin. Because it does that, we also use that as sometimes an antidote. The patient does become unresponsive to warfarin for about a week after the administration of vitamin K. Our forms of vitamin K include vitamin K1 and vitamin K3. Remember, K2 is the type that's made in the gut. So now let's take a quick break. We're going to come back and watch part 2.